Hey everyone, if you're watching this video, it means I got called in as the backup hospitalist at Memorial. But I still wanted to help kick off this retreat. I'm really excited for all of the ideas and conversation that's going to happen today. Your early clinical learning leadership team, Susan and Chris, have been working really hard on pulling this together. And I'm hopeful that we are going to reflect on the year behind us and have some really exciting discussions about what's to come. With that first year of Vista behind us, there is so much to celebrate. I'm just so proud that we pulled this off. I think it's a testament to the quality of the faculty that are teaching our learners and the section leaders, and of course our ECL co-directors. By the numbers, I thought I would point out a couple of things. With Vista, we have a new commitment to longitudinal progression and assessment tracking for our learners. And part of that involved more formative data records. And so a huge thank you to our ECL small group facilitators who completed more than 1,000 student performance evaluations. They had a completion rate of 95% for those. So that's really impressive. Those are all milestones based. So all that data goes in the portfolio. The physical diagnosis workplace-based assessments and the hospital sessions workplace-based assessments are also milestones-based, and learning community mentors constituted about 75% of those, and then about 25 to 30% were completed by volunteer faculty or the ECL small group facilitators who came over to hospital sessions. And that we had a completion rate of about 77% when you look at that in aggregate. So that's a lot of data about our students and how they're progressing along the milestones. I want to have a particular shout out to our education program specialists. So we have 4 very dedicated education program specialists in OUME who've worked hard with the section leaders, Gary, Elizabeth, and Garima, to deliver this curriculum and to operationalize it. We have put together over 400 unique small group sessions. We've delivered over 300 hours of curriculum, and so that requires a lot of operational planning and space use and planning for space. On Blackboard, we've posted 58 sets of materials, student instructions, faculty guides. So that's a lot to be proud of. And the students seem happy with the curriculum so far. Our overall rating at the end of the semester was 3.5 out of 4, which is stable when you compare that to our link curriculum in when we called it DCS back then. I also think our faculty are pretty happy, and a testament to that is how many people we had apply for the 2 major roles for early clinical learning. We had 26 applicants for the 5 learning community mentor roles and 20 applicants for our 4 ECL roles for the new learning community. Now, our early clinical learning is different in Vista than it was in Link. We are really focused on longitudinal skills, and we've boiled that down to 7 essential skills. If you look at your packet, there are 2 documents I'll call your attention to. One is our objectives, our early clinical objectives that the build team put together almost 2 years ago now when we were planning out Vista. And every objective there relates to one of these skills. Of course, we teach communication skills, very much so in the ECL small groups, but really across several of our ECL activities. Examination skills are taught across several activities, but most robustly in the PD curriculum. We are teaching technical skills, health system science incorporation, the skills of self-reflection and feedback, and how to care for diverse populations. We even start some early clinical problem solving in the early clinical curriculum. So those are our longitudinal skills, but we also in Vista have tried to make our content block related whenever we've been able to. And so what is that content we're talking about? Well, if we use a case to set up a scenario for our communication skills, we want that case to really be in the system the students are learning. If there's an interview component that correlates to the system, we try to put it time-wise in that system. So an example of that one is like the nutritional history in the GI block. We try to make the POCUS body area for that session correlate to the system that the learner is in. And the same with PD, but I think we've had some varying success with both of those last two items, actually. I know many of you have seen this learning and forgetting curve. It's something that Dave Hayden showed me a while back when he was talking to a group, and it really resonated. I think it's a great thing for educators to have in mind, particularly educators like us that are teaching learners specific skills. And the idea here is, and this was put forth by a German psychologist. I cannot remember his name right now, but back in the 1800s. And the idea here is that you teach a learner something, and there is almost immediate waning of that memory. Most loss occurs immediately following the lesson, and then that rate slows down over time. You can mitigate that by contact with the learner and reintroducing the principles or ideas. So the little icons up here show an email, outreach by phone, a small group conversation, or office hours. And that brings the principle or the skill back up in the forefront of the learner's mind. And again, that decay process starts almost immediately. And so that's the learning and forgetting curve. This same psychologist also said there were some other important components that I think are relevant to mention, that the learner's state when they're receiving the instruction or learning the concept is a really important consideration. So learners who are, how they feel is important. And also how organized the material is presented to them matters as well. So this fits really well with the VISTA system. So we used to think of in LINC specific activities or courses like hospital sessions or PD or DCS small groups. In VISTA, we're really hoping to move towards talking about skills, which occur across activities, rather than focusing on activities themselves. And so you remember that list of 7 longitudinal skills that we think we deliver on in ECL. I just pulled out 3, probably the 3 major ones that we teach in ECL: communication or interview skills, physical examination skills, and health system science skills. If you look at communication, there's really several activities week to week where communication skills can come up. Of course, ECL small group, which is most deliberate and most robust. But they also will practice history taking and counseling in their longitudinal preceptor's office. They're going to practice that history again in hospital sessions. And so when you think about that skill of communication or interviewing skills, specific skills, and that forgetting curve, although an individual hospital session may be spread out, that's not the only place that they're learning to interview. And so seeing how these skills translate across the various activities is really important. Similarly, with physical diagnosis, most robustly taught, obviously, in the PD thread. But again, they're practicing examining patients in LPP. They're practicing examining patients in hospital sessions. And we also have new activity POCUS, where there is a lot of anatomy and physical diagnosis that occurs in that activity as well. Health system science is the 3rd longitudinal skill that I want to use as an example here. And this is probably the most prevalent throughout our various activities of ECL. ECL small group, LPP, they see the office operations, they see interprofessional learning, even some policy stuff. Operation House Call, which is a new piece of our early clinical learning around neurodivergent patients or patients with intellectual disabilities that come in with their family members and caregivers and teach our learners directly. There's quite a bit of healthcare policy that's discussed there, and social determinants of health. We have a brand new social determinants of health curriculum that launched after the P2 block in this new ECL curriculum in VISTA that has 4 sessions as well. And certainly that's a big domain of health system science. So with that in mind, thinking about longitudinal skills and how we try to make the content block-based where we're able, I want to review the year with you using the 5 blocks that our learners have completed in the VISTA curriculum, looking at what the ECL activities are for each of those blocks, and then discussing what the changes are for each of those blocks. And I'll try to be as efficient as possible around this. So the first block is building working cells and tissues. This is where our learners learn about genetics, cellular biology, biochemistry, and we do some foundational learning in ECL. They do an independent learning module for orientation. Their first ECL session is about the patient-physician relationship. The white coat ceremony and the preparatory session in front of that is in this block. They learn the Cardinal 7 features in their second ECL session. We had a new activity called multidisciplinary rounds, where we did some early clinical problem solving with Mass College of Pharmacy students and our own Graduate School of Nursing students. ECL 4 was about heritability and the value of the family history, which aligned nicely with some genetics that were being taught on the Monday, Tuesday, Thursday, Friday of the week. Problem solving case in that correlated to the block was small group 5. We had a simulated patient encounter, low fidelity simulation, where our students practiced obtaining consent for genetic testing. And then we had our first 2 physical diagnosis activities, where PD1 was around vital signs and PD2 was around examining the heart and lungs. There was also time for students to work with their longitudinal preceptors in their offices, clinics, or in the hospital or emergency departments. That was really an orientation type session. So there are some plan changes in the block, the biomedical components of the course. They're planning more small groups, taking a page out of our book on that front. We are actually going to do away with the genetic counseling simulation, although it fit well within the block. It's kind of an advanced clinical skill and seemed out of sequence for our learners. We've also learned that delaying this multidisciplinary rounds activity to a later block might make sense. In the second principles block, this is called Foundations of Disease, Prevention, and Treatment. This is where learners first experience pharmacology and the basics of pharmacology. They also have the basis for their cancer concepts longitudinal thread established here. And this is where they first learn about epidemiology and the social determinants of health. For ECL activities, we teach breast, abdomen, and lymph nodes here. They have ECL sessions on race and medicine, social history and the determinants of health, the physician as the advocate, immigrant and refugee and migrant health. They have their first testing scenario in OSCE 1. There's also time for an LPP session as well. Operation House Call can occur in any block, and as you may have heard me say, this is our new curriculum this year around caring for neurodivergent patients with intellectual disabilities, and it's actually taught by patients and their families. It's followed by a home visit, so each of our learners in pairs go do home visits with families that are volunteer faculty, if you will. This block actually, in the next iteration of VISTA, will have 1 week of added time. That is primarily going to be used for anatomy. The anatomy and biomedical faculty have heard loud and clear that mentors wanted more anatomy prior to getting into the really hefty PD sessions. There's going to be less pharmacology in this block. In fact, the autonomic nervous system was previously taught in this block, and that's going to move to skin and musculoskeletal, which goes along a little bit better with the anatomy and the sequence there. The DIO's office is going to help us oversee and further develop the race and medicine session. And then we're going to start introducing blood cells and the lymph system here in order to prepare them for the following block, which is BII. I think that goes nicely with the fact that we are teaching the lymph node exam during this block. And then finally, there's going to be an intro to nutrition, which is one of our longitudinal threads throughout the curriculum. And there's going to be some robust connections with social determinants of health and food insecurity there. Blood, immunity, and infection has a lot of content for ECL. This was the first time we had a practice OSCE. The students had to gather a history and physical for an endocarditis case. This was in a person with IV drug use. This was optional. About a third of the class signed up for that. They learned the neurologic exam. This is quite early for them to learn the neurologic exam. That was partly by request of the NSB faculty. They wanted it in advance of their block. The students had their second multidisciplinary round session, which was an end-stage renal disease case, again, interprofessional learning with Mass College of Pharmacy and GSN. In the ECL small groups, there was also a physician self-wellness session. They did the complete history and oral presentations, obtaining a sexual health history, gender diverse health, and they had their first hospital session with an intro to the hospitalized patient. Point of care ultrasound also made an appearance. This is the first session, basically an intro session, learning how to use the machine and the equipment. There's space for an LPP session, and this is where learners are being encouraged to now interview and start examining patients. And this is where the first social determinants of health session occurred, which was a community scavenger hunt in mentor teams. And there was space reserved for the second social determinants of health session, where learners were supposed to participate in service learning time and select the determinant of health that they wanted to learn more about. This block has less time in the second iteration of VISTA. Some of that material about the lymph system is moving into the block ahead. For ECL, we're taking the adolescent health session out of this block. And the DIO's office is going to assume ownership of the curriculum for gender diverse care. And then ECL faculty, it's going to be optional to be present for that. We have 3 blocks remaining in the year. We're almost there. The skin and musculoskeletal system is the first time we're really in a body system. This is where they learn the musculoskeletal exam for PD. Previously, we did adolescent health here. Which is moving, which we just talked about. The third multidisciplinary rounds exercise is here, and that's a diabetes case in this one. The anatomy debrief is coupled with a motivational interviewing session in the first iteration of VISTA. ECL 18 is counseling for health. OSCE 2, our second testing event, happened in the skin and musculoskeletal block. The second hospital session for most learning communities happened here as well, and this was around navigating the EMR and collecting the HPI. The second POCUS session occurred here, which was neck anatomy, lower extremity anatomy, and there was some reference to putting in a peripheral line. The fourth LPP session, there was protected time, and our learners did their third social determinants of health session. So remember, I did say that the autonomic nervous system pharmacology is moving into this block so that it's coupled with their anatomic dissection of the autonomic nervous system. For ECL topics, the MDR topic is changing to ethics, it looks like. And our anatomy debrief is changing a little bit too. There's going to be some learning around trauma-informed care rather than motivational interviewing. And again, adolescent health is moving out of this block. Nervous system and behavior, which is the second to last block of the first year, is really like a behemoth of a block. The second practice OSCE occurred here. This was a Parkinson's disease case where the history and physical was actually recorded, and then the learner had to watch the recording around this patient presenting with tremor and do an oral presentation. PD5, head, eye, ear, nose, oral exam, and throat exam is the content of that session. And then there's a second session, because this block is so long, which was an opportunity to integrate everything the learners had had in PD to date. There's a number of substance use ECL sessions, so alcohol use disorder, opioid use disorder. There's a session on behavior change counseling, a session on the older adult and advanced care planning. We start our clinical reasoning sessions here, and the third hospital session is focused on documentation. The fourth hospital session is a simulated one, and it's a new feature in the VISTA curriculum, but the standardized patient is portraying a stroke patient, and then the student gets to learn from and hear from the multidisciplinary team. So POCUS, the third session, happens here, and this is following MSK. They do knee, shoulder injection and aspiration. They have opportunity for longitudinal preceptor sessions 5 and 6, and they do their final social determinants of health session where they're presenting about what they've learned through their community service learning to with their determinant of health group. So not a lot of stuff is planned to be changed. This NSB block was quite successful. And I wonder about our ability to move the neuro PD session closer to this block. That's something that I think we can talk more about today. Finally, and this is one of the last 2 slides, the gastrointestinal block. ECL sessions that are very block-based, gathering a nutritional history and nutritional counseling. There was an opportunity to revisit the complete history. We talked about professionalism and oaths. The third testing event occurred in OSCE 3. We had another simulated hospital session, and this was for an inflammatory bowel disease patient panel and a patient, standardized patient who is portraying a new presentation of abdominal pain. POCUS is about the liver, gallbladder, and appendix. They also do a simulation around ascites during that session. And there was protected time for LPP again on a Wednesday in the GI block. So there are not a number of block-based changes here. ECL is removing, it looks like, the nutritional counseling session and adding another clinical reasoning session. And we're hopeful to expand OSCE number 3 this year to include a history and physical so that it is more reflective of the multiple longitudinal skills that we are teaching. So I'm just bringing you back to this concept of the 7 longitudinal skills that we are teaching in early clinical learning. You've heard a little bit about how we've attempted to make these block-based. The value there is that it reinforces the learning that the trainee is experiencing in the rest of their course, right? So these are all one course, and it helps to cultivate some relevance in the clinical skills that we're teaching. And so with this learning and forgetting curve, it's important to think now about skills rather than activities. That's consistent with our VISTA model. But this does necessitate that we talk to each other, that we have an awareness of the skills that are being taught across the activities in ECL. And I'm hopeful we can talk about more successful ways to make sure everybody is aware. I will hand it over to Susan and Chris to kick off the rest of the retreat. And again, I'm so sorry I can't be there. I would rather be with you than in the hospital. But I hope that there's lots of thoughts and interesting conversation and action items that come out of today. So thank you.